Okay, thank you, Jin-Gyun. The next speaker is Dr. Jae-hyun Park, and he will talk about the laboratory. He will talk about the laboratory experience with COVID-19. Dr. Park, please.
Hello, I'm Hyeon Park, Department of Laboratory Medicine, Seoul National University Hospital. Today, I'm going to talk about laboratory experience with COVID-19. The contents of this presentation are rapid response of Korea, COVID-19 test, and other laboratory tests in SNUH. COVID-19 test includes specimen collection, transport, handling, facility, workflow, statistics, and inconclusive research. Guidelines have already been published by various organizations, including WHO and CDC. So rather than a summary of these, I'm going to talk about what we are doing. As of April 20, a total of 560,000 people were tested for COVID-19 in Korea. The blue bar graph shows the number of negative results. And in early March, Korea tested about 18,000 people per day. Currently, more than 100,000 tests have been performed in the US, but in early March, no other countries have attempted this. Now the number of confirmed cases per day falls to less than 20, and the number of tests in around 7,000. There are also public laboratories, but large clinical laboratory centers and hospital labs played a significant role. The reason Korea was able to respond so rapidly is that it made the system after the MERS outbreak in 2015. First, diagnostic kits were developed quickly, and the government authorized the emergency use. Korea has national insurance, which has decided to cover tests for suspected and confirmed patients with COVID-19. Medical institutions that can perform the test are accredited labs that have molecular labs, have completed training for COVID-19, and have passed on external quality assessment. Now I'll talk about COVID-19 laboratory experience at SNUH. Subjects are COVID-19 patients, suspected patients at screening clinics, and pre-admission patients. Recently, pre-admission COVID-19 screening is being conducted. In Korea, there have been cases of hospital outbreak, and it was implemented as preventive measures. About 3,300 patients are tested every day, and results are also sent to patients by SMS. A nasopharyngeal swab is used as the primary sample according to the guidelines and experiences. The direction of pre-admission patients and screening clinic patients are different. At the central building, 2 doctors are collecting samples through the window. Doctor's PPE is an N95 mask, face shield, and gloves and surgical gown. When collecting samples, polygraphs are worn on the gloves and are changed for each patient. Initially, a triple packaging system was used, but the volume was too large for sample processing. Therefore, the COVID-19 patient sample is now transported using a zipper bag and a plastic container. Screening specimens are collected, labeled, placed in zipper bags, and stored in the refrigerator. They are transported in a large plastic container according to the test schedule. The carrier is wearing gloves and transporting the sample through an elevator assigned to the COVID-19 specimen. The processing room in the molecular diagnostic unit is BSL-2 with negative pressure. In the room, there are two Class 2 BSC and nucleic acid extraction machines. Specimen handling is the most laborious and time-consuming procedure. The medical technician wear N95 mask, apron, and gloves. Due to the disinfection procedure, the technician opens the zipper bag, reads the label, check it together, and cleans the tube. After the technician opens the tube and records the samples for the nucleic acid extraction. We use Roche Magna Pure 96 for RNA extraction and Biorad CFX 96 for real-time PCR. We have to use KFDA-approved reagents for COVID-19 tests. Initially, the first approved Cogen Biotech kit was used. This kit uses eGene for screening and IDIP gene for confirmation. The probes sequences were developed by Coleman et al. As the number of tests has increased, the later approved SD biosensor kit is being used now. By multiplexing fluorescences, both genes can be identified in one wear. In general, the total test time takes 6 hours. The real-time RT-PCR itself is about 2 hours, but it takes 1 hour for RNA extraction and 1 hour for RNA setup, PCR setup. The most dangerous and time-consuming step is the sample preparation. If done carefully, it takes about 2 hours to prepare about 90 samples. The test is conducted 4 times a day, 10A, 1P, 4P, and 8P. Currently, 9 medical technicians are conducting COVID-19 tests. The maximum capacity is 376 tests per day. From February to April 15, a total of 601,000 samples were examined. Among them, 5,600 samples were referred from the hospital, and 500 samples were requested from a center for mild symptom patients. During follow-ups of the COVID-19 patients, there were many positive and inconclusive results. The number of tests increased steeply due to the pre-admission screening. The guidelines recommend a determination of a positive result only when all genes are detected. If amplified only in the E gene, it is said to suspect another beta coronavirus. Conversely, if there is amplification only in the IDIP gene, it is said to be retest. It is important to check the amplification curve for interpreting the results. A positive result is when certain amplification is confirmed before threshold cycle. It is negative if the curve is at the bottom. But what should it say if amplification appears behind the threshold cycle? Although different from the guidelines and manufacturer's criteria, we report it as positive if such amplifications are found in both genes. The inconclusive result is due to amplification in one gene or high CT value. The most important factors are the dynamics of viral load and specimen quality. Both examples were identified as COVID-19 positive from another lab. For the lab, our laboratory results were positive, but high CT values. The results became positive, but then inconclusive. Therefore, nasopharyngeal swab and sputum were examined together, and only one side was negative. On hospital day 29, both samples became negative. Let's see the right one. In our lab, the results were inconclusive, positive but high CT value, positive and positive but high CT values, positive and negative. In the follow-up tests, results can fluctuate. Therefore, we report results including CT values in consultation with the infectious disease doctors. The possible causes of false negatives are similarly described in various guidelines. Specimen quality and viral load dynamics are important. Other factors including viral mutation and the effect of treatment. In this case, it is necessary to test a lower respiratory tract specimen such as sputum. Besides, it is also important to always test both positive and negative controls for the quality control of PCR. Recently, false positive results were reported in Japan due to contamination. Performing other laboratory tests or risk assessment for aerosol generation is necessary. For CBC and routine chemistry, we assigned automated analyzers for COVID-19. Microbiological tests and other tests are mainly operated in Class 2 BSC or with measures to reduce aerosol generation. Thank you for your attention.